Well, I'm of course greatly honored to be here to talk about cord clamping, and I would like to disclose that I just read that I don't have any interests in anything, and then I realized I've been researching this for 13 years now, trying to elucidate different questions. So of course I have some sort of conflict of interest in this area. I hope to address these questions during my talk. What is delayed cord clamping? What happens during delayed cord clamping? How long is appropriate to wait? Effects on preterm infants, effect on term infants. What about jaundice and cord clamping 2.0? And I would like to ask to start with this slide low app, and you could answer what would you say would be delayed cord clamping in your own notion for preterm infants? And let's say, to make it easy, less than 32 weeks or something like that. And I won't give you a lot of time, so please hurry. It's nice to see that now it's 36 that's answered. So I think I'm happy there, Francesco, if you could change to. So it's 60 seconds, 1 minute, something like that. That is the question. So it's really not this. It's quite different answers. And if we go to the next question, what would it be for term infants? So here it comes in a different order, but it seems like if there is a majority vote here, it would be less than a minute in a preterm and about 2 to 3 minutes in a term infant, with some differences. Well, to start in, we can of course say that the guidelines, they help us to define what is delayed cord clamping. And the first guideline that I know of came from Sweden in 2008, and there it was defined that delayed cord clamping for term infants was 2 to 3 minutes, and for preterm infants 30 to 120 seconds. Very wide approach there. WHO in their latest guideline say more than 1 minute or more for term and preterms. In UK, the NICE there, they say 1 to 5 minutes, and they don't say anything special for preterms, so I suppose they mean that it's 1 minute or more also in preterms. The ERC, or the ILCOR guidelines from 2015, they say in a healthy, this is an infant that don't need resuscitation, you should wait more than 1 minute also for preterms. The American Association of Committee of Obstetrics and Gynecology in 2017, they say 30 to 60 seconds or more for both preterm and term infants. And Italy, which came with the latest recommendations, I'll return a little bit to that, say for term infants 1 to 3 minutes, for preterms 60 seconds if less than 29 weeks, and more than 90 seconds for those over 29 weeks. So from your answers, there is a lot of people that are perhaps a little bit more conservative regarding preterm and cord clamping than the guidelines say. I already now want to recommend reading these Italian recommendations for placental transfusion strategies, because this is the best approach yet in doing grade and evidence-based through all the kind of different questions you have regarding delayed cord clamping. You will have a very good read through the literature and grading the evidence for everything from milking, cord clamping during cesarean, everything. And I think that we would trying to put that into the USB master folder. It's an open access paper. So you defined cord clamping. Do you know when it's performed at your workplace? Do you have any? Perhaps we should have, I don't know. Or you put it in, Francesca, I think. My notion is that we don't know it as a lot. I would have answered. I'm not really sure when the obstetrician do it. So if this is true, we don't really follow the guidelines either. And what about delayed cord clamping and term infants? And this is, the answers here are reflecting my impression that we are really conservative regarding delaying cord clamping. And as I'm a researcher in the field, I usually think that the guidelines are conservative because it usually takes 5 years or more for the guidelines to gather enough evidence to do a recommendation, which means that the 1 minute recommendation for preterms and up to 3 minutes recommendation for term infants, that's evidence that are at least, I would say, 5-10 years old. And still you can see that the community is even slower in adapting these differences. And one thing is for sure, it's not about resources. It's not about it's costing a lot of money. We don't have to buy a very expensive machine to do delayed cord clamping. So I just want to walk through what happens during delayed cord clamping, and I will mostly address term infants. That's what I've been doing my research on, but you can apply most of it on preterms too. So well, actually in a term infant it comes down to 1 deciliter of blood, which I try to express here. And I think that's one problem is that you look at this deciliter and think, what the heck can that make for difference? Is that really so important, this little small amount of fluid? And of course, I try to say that, well, this is 2 liters of blood if you are a 70 kilo person. And then suddenly, perhaps you get the notion of what kind of amount it is. And then it's just 3 minutes. How could this have any difference in the newborn's life? And we know that it's about 1 deciliter in full-term infants. And this was research performed in Karolinska University Hospital in the 60s by a Swedish professor and American researchers, where you can see here the blood. It empties from the placenta. Is it that one? The placenta, there is less and less blood there and more blood into the infant, from 70 milliliters per kilo up to about 100 milliliters per kilo. And here you can see it. Here is 1 minute, and in their experiments, there was still a transfusion going on for the next 2 minutes. This was nicely repeated by a group in England that put the newborns on a scale, and they had second by second weight of the baby. So it started, this is just one example, at 3.4 kilos, and that was this is 1 minute, an early rise, but it continued up to 5 minutes, the rise in weight. And they said that it's contributed with about 24 to 32 milliliters per kilo, which amounts about 1 deciliter of blood per kilo. And as you know, you tend to, or when you would want to do a blood transfusion, you say 10 to 15 milliliters, and you think, should I give furosemide too? Here it is 24 to 32 milliliters per kilo in 3 minutes. Just think about it. This is a nice way of seeing what happens, and not until I saw these pictures I didn't have realized that the midwives, they really see when the transfusion has ended, because they see this umbilical cord in the beginning, and then they say that it's starting to get a little bit less full, and it ends like this. And there is a hashtag wait for white among the people that want to delay cord clamping among lay people or among midwives and so on. So it's quite easy for a midwife to say when the transfusion has ended. So what about the effects on preterm infants? A little question here. If you have read or heard about this, there is a systematic trial overview published 1.5 years ago, compromising 18 trials, 2,800 infants. And they presented numbers on the relative risk of hospital mortality after DCC compared to ECC. What could it be? And when it comes to preterms, it's 60 seconds perhaps. I think it was about that in this paper. So the risk is lower. Oh, no. Oh, yes. So that's great. Yeah, you should think that. 16% lower, that's a good effect. But it was actually 32%. The mortality was lowered with 32%. And this was not one study, as you see. It's 2,834 infants. You don't get much more evidence than that, I think, on mortality. So the theory about the preterms is that you have delayed cord clamping. There is an extra placental transfusion. It will give higher hemoglobin, which means less anemia. You will have a larger blood volume, which will have a more stable blood pressure and urine output. This would hopefully, or in theory, give less morbidity. And it's by your own thought easy to think that it should be the IVH and the NAC that's mostly affected, and then mortality, and this would give more optimal neurodevelopment. The latest Cochrane report is from 2012. I know that Heike Rabi is hoping to publish a new one this year. I think she's the group is ending a new report right now. But if we just look at their main findings, it is exactly what we expect. And this was 15 studies, 700 infants between 24 and 36 weeks. Well, the maximum was 180 seconds, but most of the studies was before 60 as a delayed or immediate. It was associated with fewer infants requiring anemia, transfusion for anemia, 0.6. Less IVH, also 0.6. There was in this report a 40% reduction in all IVH, not in severe, but in all IVH, and also the same reduction in risk for NAC, necrotizing, whatever. And there is a more recent, and that's the one I cited from the beginning. There is this, a recent systematic overview from a group in mostly Australia, which was published 2017 in the autumn. And now they have 18 randomized control trials with 2,800 infants. And they see the same thing about anemia, reducing the transfusion, but now only with about 20%. There is less IVH, but it's close to 1. So if we are talking about significance or not, there is at least a 13% less IVH. And then the reduced hospital mortality. 18 trials, 2,800 infants, 0.68, with a confidence interval that's 0.52 to 0.90. And as you see, it's very important for me to stress the amount of evidence for preterm infants. So what about the effect on term infants? And here is another question. This is also a systematic overview, but this is 5 trials, 1,152 infants, where they compared cord clamping before and after 60 seconds. And this is the risk of iron deficiency after ECC compared to DCC, which means that how much higher or lower risk does an early clamped kid have for iron deficiency compared to a delayed cord clamped kid. So most of you has realized that delayed cord clamping in term infants, it reduces iron deficiency. It's much higher risk to have iron deficiency as an early clamped child than a delayed cord clamp. The right answer is 2.6 in this systematic overview. In Sweden, the risk of having iron deficiency at 4 months in our RCT was 9 times as high in the early clamped group than in the delayed clamped group. The framework for the placental transfusion model in infants, term infants, we can progress it a little bit more. Delayed cord clamping gives this extra blood transfusion of about 30 milliliters per kilo. You get higher hemoglobin, then you have which means that you have less anemia directly after birth. You have the hemolysis and the iron. As you know, we cannot actively excrete iron. We don't have any mechanism of getting away with iron unless we bleed. So it stays in the body, in the iron stores. And in that way, you can avoid iron deficiency. And that will, in the upcoming years, could give less, you can protect you from anemia, and it can optimize your neurodevelopment. Also here, the latest Cochrane report is quite old. It's from 2013. And it's 15 trials with 3,911 term infants. They compared 60 seconds before 60 seconds were early, and after 60 seconds was late, as they call it. And the early ones, they had 101 decrease in birth weight. And it's so nice to see that we are talking about 1 deciliter of blood being transfused. And in this systematic trial, it's exactly 100 grams. That is the weight difference. It's really beautiful when the hypothesis and the numbers, they are so close to each other, because we, of course, interpret that this 100 grams is the blood transfusion. There is a lower hemoglobin in the early clamped children. It's 15 grams per liter at 24 to 48 hours. And there is an increase of iron deficiency of 2.6 at 4 to 6 months. That's on 1,100 infants. After the publication of this, we have produced quite a lot of new results after 2 RCTs on cord clamping, 1 Swedish and 1 from Nepal. They are quite similar. The Swedish one, we included 400. It was 180 seconds and less than 10 seconds in the 2 groups. In the Nepalese, we had 540. It was more than 180 seconds or less than 1 minute. The follow-up was in the Swedish blood and iron status at 4 and 12 months, but in Nepal we did it at 8 and 12 months. And we looked for bilirubin, and we have done neurodevelopmental follow-up. And here I've just gathered our results on ferritin together with the two, I think, largest international trials. And this is the Swedish trial where ferritin was 45% higher in the delayed clamp group in Sweden. And this was immediate and 3 minutes, so it should be quite large difference. And it was 4 months. Chaparro, in the Lancet paper from 2006, showed 47% more ferritin in the delayed clamp group. This was a 2-minute delayed cord clamping. In Argentina, they had immediate and 3 minutes. There was a 60% difference of ferritin still at 6 months of age. So this iron stays there. And in Nepal, we could see still at 8 months, there was a 33% higher ferritin in the delayed clamp group. And this was comparing 1 minute with 3 minutes. So even if you wait from 1 minute to 3 minutes, you will still get 33% more iron at 8 months. In this Nepalese study, we could still see an effect that was significant on anemia. There is a lot of kids having anemia in Nepal. It's about, as you see, 80%. And there was a reduction with about 10% of the anemia rate. And there was also at 12 months some sort of reduction in iron deficiency, but that was not significant. And of course here, what you eat and so on comes into, you have to take that into account. So then there is the optimal neurodevelopment, and I think that's perhaps the thing that is most important in the high-income countries, because I was in Copenhagen at the EAPS meeting in 2000 and something, 12 or 10, and presented these iron deficiency numbers. And then there was a neonatal nutritionist who said, well, this is really interesting, but that won't matter for the baby in the future because they will get iron-rich foods and they will sort this out. And iron and development, there is a lot of, I don't have the time to go through all the research, but there is a lot of research looking at the hippocampus and also the striatum of the central brain. The myelinization seems to be very sensitive of iron deficiency. It's seen in a lot of studies that it goes slower and it works less good if there is iron deficiency. And then especially the dopaminergic neurons, which, as you know, has to do with, I don't remember the English word, but behavior at least. So in Nepal, we had the columns here. It's how many babies that has negative result on their tests. And the blue ones are early clamped and the red ones are delayed clamped. This is at 12 months. And you can see in the ASQ, the total score was, there was 47% being at risk in the early clamped compared to 23% in the delayed clamp. And there is this tendency through all types of testing. But this was not, when we did correlations, this is correlated with the anemia or the hemoglobin at 1 month of age, 1 year of age. So this is mostly correlated with that, not the iron content. And that is because the things that develops during from 4 to 8 months, where delayed cord clamping has its highest effect on iron, that you won't see until later. But still, even in a country with a lot of anemia, you will seem to be finding positive effects on the children's development, and even so. As for the Swedish results, I'm not very happy about this slide, but anyway, we did neurodevelopment in Sweden. So we looked at with the ASQ, and we saw that the children, in delayed cord clamping at 4 years of age, they had this was, normal pregnancies, normal babies in every aspect, healthy women. So they had an IQ of 110. This was really super babies or super infants or super children. there was a difference with a positive effect on the delayed group on personal, social, and fine motor domains. The social was found both in the ASQ and in the strength and difficulty questionnaires, while the fine motor effect was seen both in the questionnaires and in the movement ABC testing. What we also saw is that this is the children below cutoff. Here is that it's almost only boys that are below cutoff when it comes to fine motor function at 4 years of age, which we thought was a little bit interesting, because I was always thinking my boys, when they were 4, they were running around playing football using their gross motor, while my daughter, she was really into drawing and putting small pearls together and so on. And well, they did both, of course, but when I think about it, that's really interesting that boys had, especially Earl Clamp boys, had a difference. That's where the fine motor was worse in these healthy, well-nutritioned Swedish children. And we looked at the umbilical cord and saw a difference in iron already at birth. Women or girls seems to be born with higher iron stores, which is a sort of research subject that we have started to look into now. How does it come that women already seem to be more careful about their iron at birth, and what kind of things affects that? What is the time now, then? I have 7 minutes. So then comes perhaps the really grand old lady and the grandmother and mother of all delayed cord clamping trials, Judy Mercer, triathlete at 75 years of age, recently moved from Rhode Island to San Diego. They did early clamping, less than 20 seconds, and delayed clamping over 5 minutes at 73 healthy term pregnant women and their fetuses. And they did MRI, looking for myelin. Because Judy, she has spoken about that all the time. We need to make the connection. Now we can see that there is a positive effect on fine motor function at 4 years. But how do we show it in this middle step? So they did. They had found a person that could do myelin content MRI to measure that. And they saw that the delayed clamp children, they had higher ferritin levels, as always, about 50% higher. The blood transfusion is about 50% more, and the ferritin content is almost always about 50% higher at this age. Anyway, what they could find was a higher myelin content at several places at 4 months of age. And I've seen an abstract now for 12 months, and they show, from what I understand, the same kind of findings at that age. So now we have the connection. We have the blood transfusion, we have the higher iron content, we have the better myelinization, and we have the studies that show better fine motor function and in less extent, but also better social function or behavior at 4 years of age. And these are all babies that has been delayed 3 minutes or more, with no at all complications. Because what about jaundice? I think you all have read about that there is a higher risk of jaundice when you do delayed cord clamping. And it all comes from this published Cochrane Report written by Susan MacDonald, who includes a study that she did in 1996 that is in her dissertation but has never been published. And more than one third of the patients in this study is delivered from her study. And as you see, the prevalence or incidence of, no prevalence of jaundice is very high in her data compared to the rest of the studies. And all of the bodies or the guidelines, they say look out for jaundice, and they all refer to these findings. In Sweden, no, this is the study from Argentina. And it was not based. The phototherapy was not based on always based on bilirubin findings, but on clinical assessment. In Argentina, the bilirubin was the same. As for bilirubin over 275, there were 2 in the early group and none in the delayed group. In Sweden, we found almost the same thing. Bilirubin was completely the same. There was no difference. While bilirubin over 275, there were 3 in the early group and 1 in the delayed group. And we had 3 children treated with phototherapy in Sweden. 2 were early clamped. In Nepal, with 540 children, we couldn't see any difference in jaundice. So that makes me say that in modern, unless this study from 1996, for studies after that, it's very hard to see any evidence at all for jaundice. There is in preterm infants, and maybe because there is a study on babies with heart failure, congenital heart disease, that also had jaundice. So perhaps when the baby is sick, it's different, but for full-term healthy infants, there is no evidence. As for cord clamping 2.0, I would like to just mention intact cord resuscitation and zero separation. As for intact cord resuscitation, there is a large team of persons from mostly Netherlands under Arjen de Pas and Australia, with perhaps Stuart Hooper being the person you hear most about, that produces a lot of very interesting findings. The first one was by, I think, Samira Bhatt as first author in 2013, that showed that, and this is very, well, I don't like this, I should do this better, but what they showed was that when you ventilate, if you clamp before ventilating, you will have an effect that, so if you clamp after starting ventilating, you will have a more stable carotid arterial flow, you will have stable heart rate, and you will have a better right ventricular output. Here is, if you clamp and not ventilating, you can see the heart rate, it goes down. Here you see the right ventricular output, it goes down. Here is if you ventilate first. These results are the same after up to 30 minutes. Green Polglass, he had the same study. He was also looking at oxygenation of the brain. So this is the brain oxygenation. Here is if you vent first and clamp then, completely stable. If you clamp first, it goes down until you start ventilating. So it has started the aspect of you should ventilate before clamping, because there is really a lot of effects, at least at lamps. What you can see is that there was an associate in Netherlands, a midwife who did home births. She looked at saturation, and you compare it to the Dawson reference numbers. I put in the 25% line here. And if you move that to the Smith, you can see that the delayed clamp children had much higher saturation, especially during the first minutes of life, while the heart rate is lower. So the heart rate, it takes up to 55 minutes for the heart rate to go up to 100. And that's completely different from the Australian studies on preterm lambs. And what you think is that it might be that there is a higher blood volume, which make the baby have a higher stroke volume, and that makes the baby that it doesn't have to have the same heart frequency. There is also less tachycardia in the Dutch delayed cord clamping group. This is Anup Katheria from San Diego, has shown that if you do resuscitation with an unclamped cord, you will have a higher cerebral oxygenation and better blood pressure after 5 minutes. And they have also done the similar study on children with congenital diaphragmatic hernia, where you can see that there was positive effects on blood pressure at 1, 6, and 12 hours if you do delayed cord clamping, while resuscitation. So there is very interesting papers on preterm infants coming out now from Netherlands, from Ronnie Knoll or Emma Brewer. We have ourselves done a pilot study in Nepal where we included 1,560 babies to delayed clamping or early clamping, and we looked at the oxygen saturation and the heart rate, and we saw the same findings as in this Smith study. With much higher oxygenation in the in the delayed clamped group. We also looked at children resuscitated. There is 231 of those. This paper is submitted, but so I can't share any numbers from you. But here is at least the hypothesis that you have the continued placenta circulation, you have the transfusion from the placenta. Both of these help to correct the metabolic situation after asphyxia. This could be improved vitality, higher APGAR score, reduced need of prolonged resuscitation, or reduced need of neonatal care. There is only a few pilot studies on this, but here is where the research are coming now. And that's both when it comes to preterm and term infants. Zero separation, I just want to mention Niels Bergman here, who was one of the first researchers on kangaroo care. Zero separation comes into that you don't want to separate the mother and the child ever. Through the operation room, preterm infants, vital term infants, wherever. And there is a great movement on that right now, and I think we will see a lot of discussions, and we will all be asked how to do that. So now I'll end with 2 questions. One is, what do you think we should call delayed cord clamping? Is it, because that's an open question, really. Usually, why do you say delayed clamping? This is not delayed, that's the natural one. So you can choose about these at least. Delayed, deferred, late, optimal, physiological, or suspended cord clamping. What would be your take on this? I agree, but the Australians has, in a way, they have, and sorry for that, Brett, in that case, but anyway, they say physiologic when you clamp after starting breathing. But I think we need to redefine physiologic till after the umbilical cord gets white. In Sweden, we have, I will say that after this question, because this is the last question. How long should we perform? And now we perhaps would call it physiological cord clamping in term infants. What would you go home and tell your spouse or your sister? In Sweden, we did a study now. In Sweden, the median, and I say the median, is 6 minutes. Half of full-term infants are clamped after 6 minutes in Sweden today. And we have a study on that too. As a final slide, I'm starting up. I've got some help on starting also a study on infant cord resuscitation here in Sweden, and who knows, perhaps in Europe. If some of you are interested in this kind of studies and research, please approach me whenever during the conference. And I just want to acknowledge my Nepalese friends. Thank you.